Hi, it's Andrew here, and in this session I'm going to be talking about the basis of disorders of hemostasis and disseminated intravascular coagulopathy as a great example of those disorders. So we're going to talk through what is normal clotting, which we refer to as hemostasis, the balance of clotting and bleeding, the disorders of hemostasis that fit into primary hemostasis versus secondary hemostasis, and then we're going to explore what abnormal clotting can look like in severe cases. And in this particular one, we're going to talk about disseminated intravascular coagulopathy. So hemostasis is really how we clot in an appropriate way and how those clots are then dissolved later at the right time. We can think about this in terms of primary hemostasis, the platelet activation and formation of a platelet plug, secondary hemostasis, which is the clotting cascade that eventually results in fibrin being released and causes this enmeshing or cementing effect, and then fibrinolysis, the resolution of that clot at the end. If we talk about the issues that occur with primary hemostasis, we're really talking about issues with platelet activation. And the really simple one is a quantitative problem. If you have thrombocytopenia, so a lack of platelets, you don't have enough platelets, and therefore you can't form an effective platelet plug. And we would generally see spontaneous bleeding that occurs when you have a platelet level below 20 and particularly below 10. Below 20 if you're acutely unwell with sepsis, below 10 if you're well in yourself. So even though the reference range is usually 150 to 400 platelets as a normal level, if you can get right down to about 10 or 20 before you have spontaneous issues. But of course, if you have a traumatic event or an operation, whilst you have really low platelets, particularly below 50, you're more likely to bleed and the bleeding is more likely to be significant. So that's thrombocytopenia. What if you have platelets but they don't actually work? There are a few disorders there. So think about medications first and foremost, because aspirin is really common and there's a lot of good indications, and there are plenty of patients out there that are on aspirin without a clear indication. And not only aspirin, but you've got stronger inhibitors of platelet function like clopidogrel and particularly ticagrelor that are becoming more commonly used because of stroke, because of ischemic heart disease and PCI, so stenting of the heart. Then you've got an issue intrinsically with the platelets themselves, and the really common one is von Willebrand's disease. This is the most common inherited bleeding disorder, more common than haemophilia A or B. That in itself is about the von Willebrand's factor. Either the factor is deficient in terms of the amount of it, or there's the right amount, but it's qualitatively deficient. It's not working as it should. So you can get both types. There's type 1, type 2, which has some variants, and type 3 of von Willebrand's disease. And that comes in various severity, mild, medium, and severe. And then there are much rarer platelet disorders themselves. So we often call these platelet storage disorders, and it's about the process that is either impaired or inhibited intrinsically within the platelet that prevents normal activation. And there's some specific testing that we can do to diagnose that. So primary hemostasis disorders, or the medications that can appear in this way, have a very particular clinical appearance, and that is that they usually have excessive bleeding. So if someone were to have a cut or a dental procedure and they have one of these agents on, or von Willebrand's disease is a really good example, they will generally start bleeding and then just continue bleeding. So there's no pause there. It's progressive bleeding that happens, and it's out of proportion to the procedure or injury. And then we can also see in a spontaneous kind of way what we call mucocutaneous bleeding. And it shows that platelets are so important in preventing spontaneous bleeding in the skin and the mucous membranes within our body. And so when you impair that process, we get spontaneous bruising and bleeding in those areas. So you think about spontaneous or minimally induced bruising of the skin, petechial rash, which is really capillary microhemorrhages, epistaxis, which is obviously the mucous membranes of the nose being affected, gum bleeding, which again, mucous membranes here, and petechial rash of the lips or gums, and then GI bleeding that will present as melena if it's upper GI, hematemesis if it's large volume, or may present in hematochezia if it's lower GI bleeding. This is an example of petechial rash, just in case you're like, what's a petechial rash? Lots of small dots, and they generally appear all over the body, but people will often notice them first on the legs, because the legs or the arms are more exposed than other areas, and then you look more, you go, oh, it's on the back, it's on the abdomen, it's everywhere. So within secondary hemostasis, we think about the areas that act like an anticoagulant, and medications themselves will look like a secondary hemostasis disorder. Those that are hereditary are haemophilia A and B, very well known for a lot of history, and they're inherited. And then there are rarer factor deficiencies like factor 7 or factor 5 that are very uncommon but still out there, and they still present in a very similar way. A lot of medications can mimic the effect of a hereditary disorder of hemostasis. Warfarin, because it affects factors 2, 7, 9 and 10. Apixaban or rivaroxaban, because they inhibit factor 10A. And then heparin or enoxaparin, as they inhibit factor 2 and factor 10A via antithrombin. The clinical features here are a little bit different. Even though you can have some of these spontaneous bleeding and bruising, the pattern is what's key here. So we'll see that there is excessive bleeding, but it often is intermittent. So it may be, for example, there's a tooth extraction, there's a bit of bleeding, a platelet plug forms, and so the bleeding stops. But then the platelet plug isn't held together by fibrin because that secondary hemostasis is impaired, and so the platelet plug can't last a long time. It breaks down, more bleeding, and then a new platelet plug occurs. And so this on and off or intermittent bleeding is classic of secondary hemostasis disorders. We also see, unlike mucocutaneous bleeding, we see that secondary hemostasis disorders cause more like an internal bleeding pattern. The classic one is joint bleeds or hemarthrosis, which is very much associated with haemophilia A and B from a young age. You can have muscular bleeds, so a hematoma that forms within a muscle, either spontaneously or with minimal provocation. And you can even have intracerebral hemorrhage. Fortunately, not as common as the others, as obviously that can be life-threatening and disabling. We've covered primary hemostasis disorders with that mucocutaneous and progressive bleeding type picture. We've covered secondary hemostasis disorders with that intermittent bleeding and more internal type bleeding pattern. Let's now look at disseminated intravascular coagulopathy, which presents us with features of both. So how does DIC start? There's a trigger, and we'll talk about those triggers in a moment. The trigger leads to excessive coagulation. So there's a prothrombotic effect in the first instance, and that inappropriately causes formation of clots within arterioles and other parts of the body. And then naturally the body then tries to correct that process by having fibrinolysis that occurs. Then, because of the clotting, we start getting perfusion defects to organs, and you'll see ischemic patterns of organ damage, whether it be the kidneys or the liver or the spleen or other areas, the brain as well. And then because of all of that clotting that's going on, you're getting the platelet supplies and the factor supplies are being consumed at a rate that far exceeds the production. The body can't keep up. And so at that point, we start slipping over from phase 1 into the second phase. Phase 1 is characterized by a procoagulant state and more clotting. And phase 2 is the sequelae of phase 1, being that we have now consumed all of our platelets and clotting factors and we've become excessively hemorrhagic. So once those platelets and the factors are depleted, you get deficient hemostasis, both primary and secondary, and you get inappropriate bleeding, which can look like bruising, it can look like hematomas, and it can look like mucocutaneous bleeding. And in some cases, you'll have a critical hemorrhage, which will be very much life-threatening. So there's a characteristic that we see on a blood film, and the process that's there is called thrombotic microangiopathy. If we break that down, it's clots in small vessels, and the pathy meaning disease, a disease of clots in small vessels. So we get this thrombus forming in arterioles, lots of small clots all over the body. We then get thrombocytopenia because the platelets are consumed with all of those mini platelet plugs being formed. And then as the red cells, which are quite large cells, go through those small vessels, they're literally shredded by those microthrombi, and that causes hemolysis and naturally an anemia that results from that. And there are features of hemolysis that you can identify. And if you want to learn more about that, check out my basic bloods or CBE and associated test video, and that talks about what we look for when we're testing for hemolysis. And so a thrombotic microangiopathy, being the process, will then have features that appear as a microangiopathic hemolytic anemia because of the anemia and shredding of hemolysis that happens in that process. So we can look for that on a blood film, and it's very characteristic. We look for anemia, so it's a deficiency of red cells generally, or sparsity of them under the microscope. We look for fragments, and you can see I've labeled some of the fragments there that often look like helmet cells or bite cells because there's bites that have been taken out of them. And then we see thrombocytopenia. So even in this, we can only see 1 or 2 platelets in that field, which we would usually see dozens. So the triggers that we talked about before that can start DIC and perpetuate it are generally of a procoagulant exposure nature. So let's look at that. We have trauma, we have tissue factor exposure because of tissues being damaged and releasing or exposing tissue factor that would usually be protected. Again, major surgery may also expose tissue factor that wouldn't usually be exposed to the blood. If you have sepsis, we can often see a lipopolysaccharide and cytokine release, and it's those that then trigger a procoagulant type effect. It doesn't happen in all sepsis, but it certainly can, particularly in severe sepsis. In malignancy, we believe that there's proteolytic enzyme release, and the proteolytic enzymes themselves are the ones that trigger that procoagulant state in DIC. You need to get rid of the malignancy to have any hope of controlling that particular DIC. In childbirth, and this is where we see DIC postpartum, there is again tissue factor exposure that wouldn't usually be there because of the process of birth. And then in severe intravascular hemolysis, that can release cytokines that can trigger a DIC type picture, but that is again a very rare instance. So the clinical features we then look for in DIC are deficiencies of hemostasis. So we look for primary hemostasis deficiency, that presents as mucocutaneous bleeding. We look for secondary hemostasis deficiency, which presents as internal hemorrhagic events. And then we look for bleeding or excessive bleeding of wound sites, whether it be surgical or traumatic. We may then see some overt thrombotic complications, because even though there's microthrombi, there may be some more macrothrombi that may present as a DVT, as a PE, as a stroke, as other arterial thrombi. We can look for those, even though they're not as common, they're sometimes there. And then we can look specifically for dysfunction of key organs that are sensitive to hypoperfusion due to ischemia. So in the brain, microthrombi can present as confusion and sedation, and macrothrombi can present with focal deficits like a stroke. Within the kidneys, we see a decreased urine output occur, and that can be confusing. If someone's septic, they're going to have septic shock with an acute kidney injury, and if DIC then presents, we may miss the fact that the kidneys are being damaged additionally to the hyperperfusion already occurring from septic shock. And in the lung, we can see hypoxia occur and hemoptysis as there's excessive bleeding into the alveoli. And lastly, if there's damage to the liver, we can often see issues with jaundice that will present clinically, and if we were to test, we would see synthetic dysfunction of the liver as well as a transaminitis due to ischemic injury. There's a spectrum of severity, and this is something that I didn't understand as well until the last few years as I've worked in critical care and hematology. I used to think that DIC was always severe and was always difficult to manage, and what I've learned that actually there's a lot of mild DIC that often goes undiagnosed and doesn't actually need specific management. So when we have mild DIC, there is evidence of coagulopathy, even though it's not severe, and there's consumption of clotting factors and platelets, but it might not get to a point of really overt thrombocytopenia or bleeding. And generally those need only monitoring and sometimes no intervention whatsoever other than hydration and addressing the underlying cause. Then we will see reasonably commonly a moderate severity of DIC. This is where we'll see some effective coagulopathy with mild organ impairment. And we need to monitor them more frequently, often in a HDU type environment, and there will be interventions that are more common in terms of product replacement and addressing the underlying cause. And at the severe end of the spectrum, we can see an overt coagulopathy, we see spontaneous hemorrhage, and we see multi-organ failure. These people need intensive care admission, and this is the group that is associated with very high mortality with DIC. So if we're looking at investigations in someone that you have a suspicion that either is at risk of DIC or has clinical features that lead you to suspect DIC is occurring, we do a complete blood examination, and we look for anemia, we look for thrombocytopenia, and we specifically ask for a blood film that is looking for features of microangiopathic hemolytic anemia, or MAHA, the outcome of a thrombotic microangiopathic process. We also will order extended coagulation studies. What do we get in there? We get the standard coagulation studies of INR and APTT, which are high because the factors are being consumed, and so therefore the bleeding time is up. And we see D-dimer because there's fibrinolysis going on, and so release of that D-dimer as a part of the fibrinolytic process. And we see consumption of fibrinogen due to clotting, and so the fibrinogen is low. And it's really in extended coags that we get that D-dimer and fibrinogen that gives us the specificity we need to diagnose and look at the severity of DIC. And then lastly, to support our assessment of these patients, and this is not looking at specifically the pathology, but the outcome and the complications, we do biochemistry, and there we look for elevated liver enzymes and synthetic dysfunction of the liver with bilirubin rise or hypoalbuminemia. And then we look at whether there's kidney involvement with urea and creatinine elevation. So if we go back to our process in phase 1 and phase 2, we can see that inappropriate fibrinolysis causes the D-dimer elevation. We see that the inappropriate thrombosis causes the fibrinogen depletion from consumption, and we see thrombocytopenia because of the consumption of platelets. And the INR and APTT elevation come from the consumption of the clotting factors. So you've just decided this person has DIC and we need to treat it. How do we manage DIC? There are 3 really key priorities of management. And the first one is to treat the underlying cause. So if it's cancer, we need to treat that cancer with chemotherapy or surgery as soon as possible. And if we can't, it's likely that the DIC will be terminal. We need to treat infection, and that's one where we might think they need vasopressor support in an ICU environment. They need systemic and empirical antibiotics through an intravenous route. We need to treat the infection with the right antibiotic or antimicrobial treatment as soon as possible. And then if it's due to trauma or surgery, we need to treat the traumatic injuries and allow healing to occur, and that DIC will be reasonably self-limited. As the patient heals, the DIC process will shut down. Whilst that's happening, we need supportive care. We need to support a return to something close to normal hemostasis. We do that through transfusion of platelets, where we usually generally target platelets above 10 if they're otherwise well, and above 50 if they're having overt hemorrhage, above 20 if they're having sepsis. If they are generally having secondary hemostasis issues, we can use fresh frozen plasma to restore more of the balance of clotting factors. If we're seeing fibrinogen that's less than 1, we can transfuse cryoprecipitate, which is effectively a fibrinogen concentrate that is derived from FFP. And then we have to be very careful with our use of anticoagulation if there is a thrombotic event that occurs in this process or prior, and we may need to hold anticoagulation or change to something that's really easily modifiable, like a high-risk heparin infusion in that instance. Our third priority is making sure the person survives all of this. And so supporting the organ function whilst we're treating underlying cause, whilst we're supporting a return to somewhat normal hemostasis. So they might need transfusion of red cells, and we generally would target a hemoglobin greater than 80, unless there's major ischemic heart disease or heart failure, where we might go more towards 100. We might need vasopressor support to support their blood pressure during this time, ventilatory support if they're breathing and they're developing hypoxia, and then dialysis if they have developed significant renal failure, and particularly the complications of renal failure like hyperkalemia and fluid overload. So that can be the medical element, but nursing is really important in the management of DIC as well, as nurses are the ones that see the patients more often, so they can identify mucocutaneous bleeding as a manifestation of disordered hemostasis as an early sign, and maybe that's the first thing that gets escalated. Also, in terms of managing organ damage, bloods are really helpful, but there are other features that we should be measuring really frequently to ensure that we're identifying further organ deterioration or that the organs are stabilizing. And their vital sign monitoring, the urine output is very important, daily or bi-daily weight measurements, and neurological observations, particularly when there's encephalopathy or stroke-like features. And then lastly, in terms of the overall management, they can provide patient education. The safe and timely administration of blood products is so important with that second management priority of hemostasis support. The blood testing is often done by our nursing colleagues, and so doing that in a safe and timely way is really key. And then maintaining safe intravenous access, so making sure that those are clean and that we're identifying where there is inappropriate IV access and obtaining better support. So there's a couple of examples here of DIC and the features that we've talked about. So Mr. B is a gentleman in his 70s, and he's diagnosed with AML, and in that course he's diagnosed with DIC. We can see on his blood picture there's a high white cell count, which is mostly made of blasts. And we can also see that he's developed a minor anemia and a severe thrombocytopenia down into the kind of 20 to 30 range. At the same time, if we look at his coagulation studies, we can see his INR is rising. It's not really high above 2, but it's definitely abnormal. We can see a mildly raised APTT. We can see a fibrinogen that's still maintaining above 1, but is reduced. And we can see a very high D-dimer, so greater than 80 initially. And as we treat the DIC and the cancer itself, the D-dimer gradually reduces. And with that, fortunately, we've maintained normal renal function and some mild liver. So in this case, we're probably thinking this is more in the mild to medium severity. And he probably only needed some product replacement, didn't need to go in intensive care necessarily. But he did have features of digital infarction and clotting in his toes. Here's another instance of Mr. I, who's a 41-year-old male who has a recurrent gastric cancer. We see in his blood picture it's a bit different. There's a number of red cell fragments, so quite high numbers of red cell fragments indicating hemolysis. We can see there's anemia from that hemolysis, but there's no significant thrombocytopenia. If we go on his clotting factors, very mild INR and APTT elevation. His fibrinogen is very healthy, and his D-dimer is only mildly elevated. So in this case, what we're really seeing is a real focus of hemolysis that is driven by a DIC that is not consuming the factors as much as in the other case. And you can see here, DIC comes in many shapes and forms, and the emphasis can move, and the balance of the manifestations of that disease can change as well. So I hope that at the end of this talk, you've now understood hemostasis and the patterns of primary hemostasis disorders and secondary hemostasis disorders, and that you can understand disseminated intravascular coagulopathy as an example of both of those disorders at play and what we do to fix that. Thanks for listening.